Thank you, Raphael. I'm not sure about that, but I'm looking forward to some conversation about how we can do clinical decision support in this space. I was going to set the scene by telling you what state of the art was, but having heard all the talks today, I think I'm going to skip that. I think you know state of the art in this space. I will talk a little bit about the current challenges we have in applying cardiac biomarkers effectively and to guide acute cardiac decisions, where decision support tools might play a role. I do think we need to think beyond cardiac biomarkers, though, about how we can incorporate imaging into these decision support tools more effectively, and I'll touch on how we might do that in the future together. So, troponin, everyone uses it. It's embedded into our guidelines. Fabulous biomarker. We have state-of-the-art pathways that give us decision support already. We also have natriuretic peptides, 2 types, 3 types. Very good biomarkers recommended by international guidelines already there with some decision support. But we still have dilemmas every day about how to make the right decisions for our patients. And I think I'm going to outline what I think some of those are, for me anyway, see if you agree. So I've spent a long time working with many of you, actually, on defining thresholds for troponin. And in the end, the reality is that all thresholds are wrong to some extent. The lower the threshold, the better the sensitivity, but the worse the specificity and vice versa. And thresholds are problematic in that way. Here's just an example showing how, if you are a youngster and you come into the emergency department, the current threshold for the diagnosis of myocardial infarction is actually pretty good. It performs quite well, a positive predictive value of over 80%. But if you come in 60 years later, then the performance is terrible. And yet we apply the same threshold irrespective of age in our practice. And it isn't just age. If you look at other comorbidities, the performance is extremely heterogeneous. And I think we ignore that a little bit and try and use clinical judgment to overrule these problems. Here's another challenge, right? Sometimes we think, well, maybe we can resolve this by pretending we don't have high sensitivity and using a threshold, good old-fashioned higher threshold to try and improve performance. But when you try and look at higher thresholds in routine clinical practice, where troponin testing is performed very widely, it doesn't actually help a lot. This is the Weriski plot, which shows you that in reality, it doesn't help us differentiate between causes of myocardial injury. And unfortunately, deltas are also challenging in routine clinical practice in that they might help us differentiate between chronic causes of injury from other acute mechanisms, but they're really no use in differentiating acute heart failure from type 2 myocardial infarction or otherwise. And then the other challenge we've had, which we talked on a little bit earlier, is early presenters. And unfortunately, when you look at this, around a third of all patients arrive in the emergency department before their troponin concentration necessarily reflects their final position and diagnosis. And we've struggled a little bit with how we apply this information into our pathways. Another challenge, these cases that end up in social media get me really wound up. But they remind me that we also find it difficult to interpret other tests in clinical practice. And actually, the electrocardiogram is critical, but isn't really formally part of our pathways. We sort of assume that clinicians know what they're doing with electrocardiogram. So here's a case of a 63-year-old with a good story, but a normal ECG and a negative troponin. There's nothing worse than saying negative troponin to me. I find that really irritating. I don't know if everyone else does or it's just me. But this wasn't a normal ECG. It shows an infralateral ST segment elevation myocardial infarction with some reciprocal change. And the troponins weren't normal. They were 15 and 18 on 2 serial tests on the emergency department, super high risk. And yet this is interpreted as a normal ECG and a negative troponin. So we need to think about how we can do better there. And we've had the ECG for 100 years. So we've been working on educating people with ECG, and we still have problems. Lastly, with some of our tests we just don't use. They're brilliant tests, but we're not using them. How do we encourage people to use these tests that we know are fabulous? So I think decision support using models could definitely help. The future is a rainbow in the Scottish Borders, double rainbow. There are some challenges too, of course, in the clouds. First attempt, this was done led by Martin Fan and a whole bunch of people a few years ago now to try and do this. And the idea was good, right? To take troponin and convert it into a probability by adjusting for age and sex, because we knew age and sex were important. The challenge was, and one of the learnings I think from this exercise, is that when you try, generalizability was touched on earlier, right? When you actually try and deploy something like this or use it in clinical practice in the wide variety of patients who are tested in the emergency department, it doesn't work very well. So it calibrates poorly, and in particular, it underestimates risk in people with intermediate probabilities, and it doesn't resolve this issue of heterogeneity by comorbidities. So we aren't getting consistent performance. Great idea, just not executed effectively when you evaluate it in routine data. So Jasper already talked a little bit about CODE-ACS, and we've heard about Artemis as well. The principles are similar. I'm not going to go over them again, but I think the learning here for me was that if you start the development of your algorithm in a truly unselected population without any selection bias to build the model, then when you apply it in different populations, it will work better, rather than doing it the other way around. It's quite important to make sure that you don't introduce bias up front in the data set that you use to train the model. The one bit of data that Jasper did not show was the performance by subgroups. So I think by incorporating other features that we know are important and influence pretest probability and also influence troponin concentration, we can make the performance much more consistent, which I think is good for equality of care, which is another topic we've touched on today. But it might also help us with a different challenge. In the emergency department, getting people not to measure troponin is impossible. Everyone loves to measure troponin. Getting them to measure natriuretic peptides in breathless patients is much more difficult. And that's partly, I think, because that people are not confident about how to interpret an elevated value. And therefore, the same approach of using the biomarker as a continuous variable and adjusting for comorbidities, age and sex, may help us to try and build confidence in the use of natriuretic peptides in acute breathless patients. And so CODE-HF is a very similar model with a probability of acute decompensated heart failure, validated in 14 different cohorts, and it provides consistent performance for rule out and for rule-in of heart failure. And I don't think we've worked as much on our care pathways and decision support for the use of natriuretic peptides as we have over the last decade in troponin. And it may be that we can apply some of the learning from cardiac troponin to deploy these tools in the acutely breathless patient to try and improve the way we stratify patients in the emergency department. But the reality is I'm an enthusiast for biomarkers, but when I'm seeing the patient in front of me, I look at lots of different tests as well. And so if we develop all our tools in our favorite test, they won't work effectively in clinical practice where we have to incorporate other things. And I'm including the ECG in cardiac imaging here because it's the oldest test we've ever had. We've had it for 100 years. I'm willing to bet in 100 years' time we're still using the electrocardiogram. It may still look like this as well. But with neural networks, we can provide decision support. Now, the first attempt to do this for acute myocardial infarction in chest pain patients was just published a couple of weeks ago, and I don't know if anyone's seen it, but it's not perfect, but they've taken signal processing, so 900 different features that come out the back end of the electrocardiogram, and build a model to try and discriminate for acute coronary occlusion in patients who present without ST segment elevation myocardial infarction. And you can see discrimination is pretty good for what they call ECG smart compared to clinical experts and the automated interpretation of the ECG. So some evidence that these neural networks, in fact, this wasn't a neural network, in fact, it was a random forest But these sorts of approaches might be able to help support decision support tool. Now, the next challenge is, the future isn't sticking catheters in people all the time. It is great because you can suck out the clot and treat the patient who actually has the condition, but the future is non-invasive imaging, clearly, even in the emergency department. And although we haven't quite worked out how to use it fully effectively, it's definitely going to be a routine test in acute chest pain patients. But we need to think beyond defining binary stenoses like positive and negative blood tests with CTs. Currently, we just tell you if there's an obstructive coronary artery. It's not good enough. There's a huge amount of information in a CT coronary angiogram about underlying plaque phenotype, biology, and risk. And we need, I think, in the next generation of these decision support tools to integrate these sorts of insights. And this comes from another AI model called AutoPlaque, developed in California, which identifies low attenuation plaque. So the dark plaque is the plaque that is likely to rupture and cause acute events. The calcified white stuff that everyone likes counting, actually, I'm not worried about that. And low attenuation plaque, is a very strong predictor of future events in patients who've got stable coronary artery disease. So if we're going to develop the tools of the future that will support clinical decisions, we're going to have to think about multimodality tests, and we're going to need to have really good data sets that are derived from consecutive patient populations without bias. So we're going to need to work together to try and generate some of these data sets. Here's some of the potential advantages. I think Raphael and I probably came to pretty much exactly the same conclusions about the potential here. Improve efficiency, improve the diagnosis by recognizing that biomarkers are raised in a variety of different conditions and using it as a more personalized approach. Reduce inequality, very important. And as Jasper mentioned, try to recognize that different healthcare systems have different priorities, and therefore flexibility in the way you deploy these algorithms is actually really, really important. And the challenges, I think we have the same challenges, Raphael, that we have to work out how to integrate these tools into the workflow, and that involves combining them with the electrocardiogram and other cardiac imaging tests. We need to train clinicians to use probabilities and move beyond pathways that tell you whether it's green, amber, or red. Individual probabilities are important. There's explainability of the algorithms and the regulations, as well as the integration challenge, which we're all going to experience. But lastly, in terms of data, one of the things I've really enjoyed about being part of the GREAT network and working with lots of you is the opportunity to share data and work together on projects. And I think particularly for this space, as we develop decision support tools, it's going to be really important that we do that because we cannot have a world where we have hundreds of these and no recommendations or guidance. So we need to work together. So we've created an open access data set of 110,000 unique patients. We haven't adjudicated them all, working on it, but a significant proportion have undergone adjudication. And we've got linked data to imaging and all outcomes, including 14,000 deaths at 1 year so far in the population, and the angiographic data. And we're trying to build this data set to make it available. And it is now available through DataLock, which is our data service to anyone in the world. And it's you don't even have to collaborate if you don't want, but you're welcome to. But the idea is you can access it wherever you are remotely to either validate or develop new models so that we can, and I think we need to work out how to do this better internationally, sharing data without it necessarily having to move. So I will finish there with a thank you to the GREAT network team and to the local team who do all the actual work. Thank you. Cheers.
Thank you, Nick, for this very inspiring talk, showing the possibilities of evolving techniques. Any questions from the audience? If not, if I may start with a particular question. When talking about medical decision support and physicians, how open are physicians in general getting support by their decisions?
That's a great question. So we have a sort of co-design team that are working on our trial design and also on the development of an interface that embeds into the patient record. And so we work with the chest pain nurses, the emergency physicians and patients and a variety of different people. They're less enthusiastic about individualized probabilities, and actually some of them like to be told what to do. So thinking about individual probabilities is going to be quite a change of mindset. But actually, like all of these things, until you start using it in your day-to-day practice, it'll be the same for me. I won't know how to use it effectively. And so I think it's very important that we do give them individual probabilities, and they learn how to use these tools, but they won't learn until they're actually using it in their day-to-day practice.
Hi, Suyam from Singapore. Thank you for the excellent presentation. Is the previous troponin level one of the few that you collect?
Yeah, I mean, we've thought very carefully about this because I think it's really important. Ideally, the reference limit that would matter is your normal value. And we have retrospective data on many patients who come in on multiple occasions, and so there is historical data there that could be fed into these algorithms that would improve, I think, increase the single test rule-out potential even greater. We haven't yet explored how to incorporate that. There's some logistical challenges in that you don't really know why they were tested previously and what was actually going on, whether that is a true baseline or not. Obviously, everyone should just have their troponin measured when they're healthy and well every year as part of their annual checkup. That would make life easier for me. But until that day happens, using the historical data is difficult. I think it is helpful, and I use it myself in my day-to-day practice, but putting it into an algorithm is quite tricky. But it's a great question.
If there are no other questions, thank you again, Nick. Congratulations.